Welcome to Collegial Conversations with Diana Clark, the professional webinar series that offers clinical and personal perspectives on issues that are common, but often not talked about. Here is today's Collegial Conversation.
Thank you for joining a Collegial Conversation with Diana Clark. Today, joining Diana is Sharon Matthew. Sharon is a licensed professional counselor, an advanced relapse prevention specialist, and a certified sex and multiple addiction therapist. Sharon has worked at care and treatment centers for over 25 years, at which she was the director of the Women's Extended Care Program for 15 years. Today, Diana and Sharon will be discussing substance use among older adults and the obstacles to recovery that are unique to this demographic. Thank you so much for joining us today, Sharon. I'm going to pass the conversation over to you and Diana.
Thank you, Laura. Appreciate that. Welcome, Sharon. It's great to meet you, and it's great to have this conversation. Not that I know anything about that second half of life, but if I did, I would love to know. I have a bunch of questions about substance use disorders and those in the 55 and older group. Can I pummel you with questions?
You absolutely can. That's become one of my favorite topics. So.
Excellent. Oddly, mine too. Excuse me. So when I first started in this field, we started to come to terms with the idea that women's recovery, and in fact, women's trajectory in addiction looked different than men's.
Yes, it did.
And what I read, and I don't know if this still holds true, but you're the perfect guest for me to approach with this. What we observe is men often go like this as they decline in step by step over decades. Okay. Women very often drink functionally 2 glasses of wine, 3 glasses of wine a day. That would have been considered functional in that day. And then they hit a certain age and they fall off a cliff, much less gradually than men. That is what my clients seem to observe. And I read that somewhere, but I don't know the data. Have you heard that?
I have probably observed that firsthand. When we opened the older adult program, of course, women were always the last ones to come into treatment. That's still, the women's census is usually lower than the men's. That's just been over time. That's been how it is. They were too busy at home taking care of everything and themselves or had their own profession. So what we're watching with that is, yes, they functioned. It sort of creeps up on, number one, the metabolism slows down in older age. That's number one. And it always was that way for women. So what I saw was a lot of wine drinkers getting very, very sick, a lot of cirrhosis of the liver, that type of thing. That is definitely, I see, more prevalent in the females than the males. But now with the men, there is another part of that. If they were the one who was out there working professionally and whatever, and then they slow down, stop, retire, or semi-retire, or whatever, then it seems to catch up because they too were pretty much functioning. But when they stop that lifestyle that they had, too much time on their hands, don't know what to do, don't know how to identify themselves other than being this person who was working and had this profession. So they too fall sort of flat because of not having a purpose, too much time, not reaching out, that kind of thing. So in older adults, what I watched was how very, very sick they became as a result of that. And as a result of the denial that everyone was in, that it was no problem, let them have their glass of wine. Oh my goodness, she's, 75 years old now. So what's the problem? But it is a problem when they're not any longer living quality of life.
So define that a little bit. When do you consider alcohol a problem in somebody's life?
Well,
that changes through life. So what are the red flags when you're older?
Well, it would be they're not functioning like they had. You're showing up at their house and they're not remembering maybe a conversation that you had. Unexplained bruises. Sometimes they fall. Older adults have this equilibrium problem. Alcohol throws that really way off. So many of the people we did receive in treatment were there as a result of a fall or an injury. It's that type of thing. And not being able to possibly hold as much liquor as they used to. So you reach this tolerance point where you don't need as much to get the desired effect. slurred speech. Now, the memory is another story. That's a whole other thing. You don't know if it's a natural aging process or the start of dementia or the alcohol, but we would have to take the alcohol away to decipher that and test for that.
Got it.
Those are some of the signs, yes.
What are some of the things? I know you're currently not working in a program where you treat older adults, but what were some of the differences that you really had to look at between treating that population and the 22-year-old adult light coming in?
So I helped develop the program with a marvelous Dr. Wang and the team of experts, the professionals, the psychologists, the clinicians. And what we found early on was there was a tsunami coming, the silver tsunami, they call it, where more people were becoming dependent on substances at a later age. And we started with 65 on up. That didn't fly. We had to bring it to like 55 on up. So what we found is that we started with a group of people getting together because we always treated older adults at Cairn, and I'm still consulting for the new program we're developing in Florida. We're going to replicate the older adult in Florida like we have in Pennsylvania, which is awesome. And I want to just start with there are 56 million older adults in the United States, and 4.4 million of those suffer from substance use of some kind. So that means a whole lot of people are out there not even being identified or seen or noticed. So what we found is they liked the fact that they were with people of their same age set, mindset, life experience. They had marriages, possibly they had children, they had careers, and they could relate much better than to maybe a young teenager. So that was an asset right from the start. And then we also noticed because of their age and maybe co-occurring issues, not only the substance use, but anxiety, depression, chronic pain, that type of thing, trauma, you name it, they again, could relate to one another. And what we found is they needed a high end on the medical unit. We needed a medical unit to accommodate this. So we built the place in Pennsylvania, and it was a godsend. It was absolutely the best thing that could have happened because there the doctors are on the first floor, the older adults are on the second floor, nursing 24/7. And I'm not talking about older age. Now, we did treat 90-year-olds, but I'm talking about people who were compromised at 55, but then too, we saw people compromised in their 40s or 30s who were on the unit as a direct result of their need of medical things. So what we also found is it needed to be a program of treating them with dignity and respect, the non-confrontational approach. They do not like someone coming at them. They're very private people. So you weren't sharing, so to speak, their dirty laundry. If you had a cost letter, an impact letter from the family, you were not sharing that in a group setting. That's an individual thing for them to talk to their therapist when they felt comfortable. So that relating to one another, the support from one another, that's what I think really sets that program off. And the slow, steady pace, these are, when you're so compromised, you do not come out of the gate like an Energizer bunny. You have to take the slow, steady pace to get them to the point where they are on their feet, moving around, because we had many people, even in their 50s, coming on wheelchairs and walkers. And then because they are oftentimes malnutrition, drinking their calories, not eating properly, very deconditioned, and it takes a lot longer time to bounce back. So that's why we were treating them in a 6-week kind of length of stay rather than a normal 4-week.
That makes sense.
Yeah.
So we've done a little bit more talking about alcohol. Let me tease that out a little bit.
Yeah.
What are you seeing in terms of other substances in that population?
So alcohol was always first, and then it was opiates for quite some time, and then benzos, the sedative hypnotics, third. I saw that switch. There were more sedative folks coming in than the opiates. Not to, it's almost like equal, but at a later stage, if you have had a loss, many doctors are just handing out Xanax, Valium, or whatever, calm down, I can't sleep, then I need a pill to go to sleep. So they became and that is a very addictive substance that you cannot, just like alcohol, get off by yourself because it could cause a seizure. Whereas opiates, you just build and build and build and have to have more and more and more for the desired effect. So, but alcohol is still safe first, but very much opiates and the benzos, very top two.
And I get where Xanax and other benzodiazepines are prescribed pretty liberally by doctors.
Yeah.
Opioids have changed. Doctors are much more reluctant to prescribe, even to those patients who they'd prescribed for decades for chronic pain. They're trying to wean them off. Are you seeing some of those people who who their primary doctor is saying, you need to come off the opiates because I can't prescribe them anymore? Are you seeing some of that?
We absolutely do. What we saw is when their script pads were sort of taken back a little bit, you can only prescribe X amount in a certain amount of time. Opiates, first of all, were supposed to be the short-term effect. You were supposed to be on it for maybe 6 months at best. And they kept giving them. And then people, and it's the hyperalgesia effect. For if you are a chronic pain person, you actually eventually have more pain by continuing to use the opiates. So it works against you. So that is why we have a chronic pain program as well that many older adults were involved in. Because people sometimes had the chronic pain condition prior to becoming substance use dependent. I had a woman who was in her 80s, never drank, never used a pill, became dependent on the opiates. She had a double knee replacement and she could not get off them by herself. So she came to a state, actually 2 months, was in a independent living. Came to us, got very engaged in the program, went back, stayed involved with NA. So she became physically and psychologically dependent on the chemical. There are a lot of those cases for sure. And they do find that once they're off of it, we use the other settings such as medical massage, acupuncture, hydrotherapy tub, physical therapy, all those things. And we always used to tell them motion is lotion. So as much as you dread sometimes getting up and moving, it is the best thing you can do for your chronic pain condition. So we also have a group once a week that they can all come and actually have their pain validated. So in many of these cases, people will say, you're just complaining again. I'm sick of hearing it. And they had no one validate that you have a true chronic pain condition.
And somebody didn't want to hear it. Both are true. Doesn't mean you don't want to hear it.
And the family messages. It's interesting. I did a group many times where I'd say, well, what was the family message around pain? And it was either suck it up or the reverse of that, hovering over them and almost making them crippled by doing too much for them. So those family messages go on no matter how old you are, no matter how long ago it happened. And
I know.
Yes, we did a family of origin group for that reason as well, because that seems to still drive the bus.
Yeah. I mean, I grew up with a physician from the Midwest whose motto was, if it hurts bad enough, it'll fall off.
There you go.
And I was like, okay, so you didn't complain about pain.
Well, doctors don't treat I had a best friend, her father used to just, move on with your day. And
right.
Just,
aspirin. Yeah. So let's talk about family members. That's sort of my area of interest. And what I wonder is how deeply embedded in a narrative the kids of your clients are about who their parents are and are not.
That's a great question. And family is my passion. I love working with families, treating families. And in the older adults, I really had my eyes open. I mean, I've done family work over time with any kind of an age group. But for this, first of all, they're in as much denial as the patient. Oftentimes, they turn a blind eye. It's not so bad until it is. So we have spouses, we have siblings still involved, and then the adult children. Now, that's a whole other story because they don't want to even think that mom or dad is struggling or an alcoholic or dependent on a chemical until things really, really fall apart. Then they tend to either hover or they distance themselves. And you have those, in the same family, you can have 3 kids thinking one way and another kid thinking another way. So the family work is so, I call it deep with an older adult and so worthwhile. Because first of all, caregivers, if they've been with someone who is dependent and struggling, they are actually worn out too from the worrying, the taking care of, picking up the pieces, all of that. So we treated we always believe that family is the patient, and that's true. So we did a lot of attention to the family members and getting them to see what they must do for themselves. Yes, I understand you care and you're worried, but, handing over to us was a difficult trick. The admissions process is really long and laborsome because I don't know who you are. I don't know how you're going to help my loved one. So a lot of validating, guaranteeing them and telling them things will get better, but also putting the spotlight on them and focusing on themselves and what they can do for themselves. Right. And then having a very solid plan, because towards the end, again, they get scared, worried, and wondering, oh my God, what am I going to do with this? Now they're coming home. So we make a real solid continuing care plan to alleviate that so they don't go back into that caretaking role and can still focus on themselves.
So that's really important. The stumbling block I seem to be encountering with adult children, and whether they have substance use issues of their own or not, the unwillingness to change holidays
Or vacation.
or
Oh my
vacation.
goodness. Well, we have a trip
We're
planned.
going to the wine country,
Oh, dear God.
right?
Oh
Yeah.
yeah. It's amazing how they don't get that, if you want this person to live and be well, there's going to have to be some give and take and some changing. And for initially, but we get together and they serve wine and I can't bother them and they can't just take that away just because I'm now in recovery. There's a lot of conversations around that. So holidays are soon coming and I can remember doing a lot of prep work and I do a sculpting of, like, they call it the dinner table, and show them what it's like when mom's there, drinking out of her mind, and then she goes off to treatment, and then the family does whatever they're doing, and they're liking this peace and calm, and then mom comes home from rehab, and they're all on the high alert again. So it is, until they take care of themselves and see that change has to happen for everybody if you want a better result. No two ways about it. But
Right.
there's that allegiance that, we can't, we always go to Aunt Sally's house and this is how it is and I can't disrupt that. So a lot of discussing that just for now, this might be the best for you because early recovery is really, really hard for anyone. And
How
especially,
do you define early recovery now?
I recall that as early recovery is the first, at least we used to say 3 months. It's like 6 months. Getting to a year is very difficult.
I call early recovery 2 years now.
Yes. And that's
Because
smart.
if we're thinking about the early recovery as that embedding new neural systems, it's
Yeah.
18 months to 2 years before
Right.
that actually happens. That's early recovery. Then it becomes maintenance.
That's right. I agree with you.
So let's talk a little bit about fellowship and the elderly. So, I have some clients who I've worked with, many over the years, who were, successful businessmen who were not going to participate in self-help
Mhm.
or any peer-driven groups.
Yeah.
How do you approach that? And how do you help them find resources that they may actually participate in? Yeah.
It is definitely an individual basis, and we ease them into it. Now, yes, we provide a meeting every night, but then we have Dharma recovery. We have 12 steps for agnostics. So we have to absolutely meet them where they are. Many will come in and say, I'm not into that God thing. I don't want to hear it. They picture AA as that kind of religious base, and we don't look at it that way. So a lot of education, a lot of influence from our spiritual team. The spiritual people meet with them and ease into that as well. And then getting them to agree with what they are willing to do. Like if it's not this, and then for the families, of course, Al-Anon and ACOA for the adult children, we really try to get them involved in that so they can focus on themselves. But it is absolutely an individual basis. Or I can remember early on when we started the program, I had 2 gentlemen that were going to rewrite the big book. And they just felt it, and they were both businessmen in control, powerful, and they thought they wanted to change it. So to each his own. But I had one guy who, what did he was a real pain when he was there, and he sent me a letter and admitted to it. And he was an executive who was used to being in charge. He apologized. And he said, no, I'm not doing that morning wellness anymore, Sharon, but I'm doing Pilates now. I said, well, good for you. So whatever it takes.
Yeah.
There's many ways to get at recovery, many ways.
Many ways. People do it in all kinds of ways.
Yes,
Walking recovery,
absolutely.
kayaking recovery,
Yep.
wherever you find that place
Yep.
of connection. But connection is pretty critical.
Yes, and that's what we found during COVID. If we had patients who had been sober, that was they kept saying COVID, COVID, COVID. I couldn't get to my meetings. I don't like that Zoom stuff. So that connection is definitely important and valuable. And I got it as I think they were in trouble with their recovery before the COVID hit, and then that just probably took them over the edge. But then they would luckily come back, which is great to get jump started again. So we also would introduce them to Zoom meetings. And two, let me just say this, recovery coaching seems to work really well with the older adult population.
That's our experience.
Good, as I agree with that. And getting them to maybe their first meeting, whatever that might be, taking them for coffee and just having a conversation. So recovery coaches really work well with the older population.
That's what we notice. We call them therapeutic coaches, but
Yes.
some are more specialized in substance use disorders.
Yes.
What didn't I ask you today?
Well, the one big thing that we focused on for us was grief and loss. There is so much of a grieving process, not just the loss of a loved one, the loss of who they were when they were working, the loss of purpose, that kind of thing. Then also sometimes the loss of a loved one. I treated many, sometimes grandmothers whose grandchild committed suicide. That is a loss that I can't even fathom. I am a grandmother. So it just, the pain involved, but then the courage it takes for them to not pick up the substance to medicate themselves is amazing. So we had a major focus on grief and loss with a grief and loss group twice a month, and then also individual session. And then that would carry through as they would move on. We would encourage them to have that with their counselor that they're going to, the therapist. So again, tying that up as a follow through. But that's a major subject for older adults.
Absolutely. Absolutely. And we experience that throughout a lifespan.
Mm-hmm.
The hits come quicker when you get older.
Yes, they do. Yes, they do.
So what's your next career move, Sharon Matthew?
So when I was tortured, am I going to retire or not? And because I still love what I was doing. I had developed the older adult in 2015. February 1st, I finally decided of this year, I think I need to I call it redefining myself, which I have. So it was a rough month and maybe 5-6 weeks, thinking I should be doing more because I was a supervisor for 21 of those years. That's responsible for programs, people, patients. Oh my goodness, everyday operations, phone 24/7. But then I found I'm really liking this. I got back into my plants, but I'm still a consultant for Karen. So I do presentations for them. I do like sometimes if they have a high profile patient, I will come in and help with the family work. As I said, that's one of my passions. So I also will help if a family's struggling to get their person in. So I'm still very involved in getting people to where they need. And then with Keel, I'm involved in consulting. They call me a clinical consultant for Keel in Florida, because that's going to open early January with another unit of probably 16 beds for older adults, which is awesome, in their new beautiful medical center. Oh. So I am not done. And then I do some private counseling too from home. I'm doing some Zoom therapy, and it gives me everything I like doing. And yet time for me. I said, maybe you don't have as much money when you're retired, but you certainly have the time. And I'm finding time is more valuable.
Definitely. Definitely. As we call money, coupons in our house. Can't get time back. You can always get more coupons. Yeah.
I also think I wanted to say that I found that it's never too late for an older adult to get well. It's never too late to intervene on addiction. And I find them very diverse, very unique, very challenging, and yet so worthwhile. I said I could watch, like when I did the women's extended care, that was anybody from 19 to 80. But you can really, really watch the older adults come to life. And that is so rewarding and worth every ounce of whatever we were doing. So,
well, let's end on that note. It's lovely. Thank you, Sharon Matthew.
Thank you.
Thank you for joining this webinar. Tune in to more webinars and sign up for our newsletter at o'connorpg.com.